ready to go. All right, we'll get this done in less than an hour, I promise. All right, I had Airway Management. Let's get rolling. So a little bit about me. It's me and my wife. We love to golf. That's cat, dog, all the above. Okay, and another dog. All right, here we go. I'm the better Airway Management specialist in our house. You know my wife did her thing yesterday, so we'll do pretty much basic anatomy. We'll go over like how to assess an airway, non-invasive airways, surgical airways, endotracheal tubes, all the fun stuff. We won't even do cases. Okay, so you guys are one of the most important pieces when it comes to having an airway before we even see it, whether or not an operating room, emergency room, anything. So you are our eyes, ears, all senses when it comes to everything, bringing a patient in. So be mindful as we go through some of this stuff. All right, so you guys essentially are the biggest predictor of whether a patient lives or dies when it comes to ABCs when you guys bring us a patient. From an 11-year study, you can see up there with our EMS activations for medical emergencies, over 400,000 attempts for advanced airways. Endotracheal tubes, percent that actually were successful went from 87 to 55%, but supraglottic or LMA airways attempts rose from 25 to 61. LMAs can get you out of trouble. I'll show you how to troubleshoot those if need be. Okay, here we go. So BVM, bag valve mask versus subglottic airways versus endotracheal tubes, and then supraglottic airways versus endotracheal tubes. We'll go through all of these. Yes, very confusing. Okay, so let's evaluate first. Biggest thing when I walk into any pre-op assessment, you can read this through. I'm not going to go over PowerPoint where you can see. First thing I'm going to look at is the patient. I'm going to say what their height is. If they're a tall person, that's the length of the airway. It's going to be longer. Do they have a beard? How big is their neck? How big is their face? What's in their mouth? Do they have dentures? Do they have braces? All of these factors are going to affect how you tackle an airway moving forward. How are they breathing? Are they retracting? Are they struggling for air? Are they gray? Are they white? Are they purple? Are they red? Are they pink? Anything. I always like to say if they're not gray, they're okay. You can turn someone from purple or blue back to pink or red. You cannot turn someone from gray back to purple and then pink. Once you hit gray, you're not okay. All right. So let's go over a quick little larynx. So you got three different areas. You got the nasopharynx, oropharynx, and larynx itself. You can look it over all of you have three paired cartilages, three unpaired cartilages. But basically this just gives you an idea of what you're looking at when you go in with your DL or your video scope, essentially. This is a basic just respiratory background about what we're trying to do with oxygenation. You guys can go over that. Do I need to touch on any of that at all? You think? Okay. Moving on. Okay, so we talked about the evaluation. Let's talk about preparation. My wife threw in a bunch of stuff from her old lecture. I'm not going to sit there and read it. I like to use the acronym SADIE, S-A-D-I-E. So you're going to have suction equipment. You're going to have airway equipment, the drugs that you need, okay, intubation equipment, and any other equipment or etc. is like what I like to use. So I always have oral airways, nasal trumpets, tongue blade, stuff like that fall under the E. But that's a quick, simple way that you can always rinse, repeat when it comes to an airway that you're quickly trying to evaluate and quickly going downstream. You can just say, okay, do I have suction? Do I have airway equipment? Do I have my drugs ready? Everything else is right there. So I use that every morning when I walk into an operating room. So let's talk about some of the differences here. I said the bottom left is your oral airways. Your nasal airways will be at the top left. We'll talk about some endotracheal tubes, types of blades, bougies, We'll talk about some different plans moving forward here. Okay, so head tilt, chin lift. A lot of times if you find someone that's unconscious, some of those bigger people like myself, or anyone with a beard or like bigger neck, their tongue is going to fall backwards. They lose that ability for their tongue to kind of get out of the way. Essentially, that jaw lift is just going to help them move air. If they're unconscious but still breathing, it's one way to quickly just like fix something. Here's another. The one on the far right is called a Larson's maneuver. Basically, taking your two fingers, index fingers on each side of your jaw, and push your jaw forward. There's a I'm trying to think of a correct word for it. God, I'm having a brain fart. Can't think of it. It's a pressure point. Excuse me. Sorry. There's a pressure point right underneath the jaw that if you do a Larson's maneuver, it'll actually, if your patient's unconscious, they'll tell you if they're truly unconscious. Yeah, it hurts. You can stick your fingers in the back of your jaw and push, and it'll wake you up real quick. I do this to wake up a lot of patients that don't want to blow off their anesthesia sometimes. Don't call me mean, but you got to start breathing at some point. I can't do it all for you. Okay, so a lot of times you guys run into possible cervical injuries that you guys have to manage because you don't know in an X-ray, MRI, CT whether they truly have a cervical injury. You need to just protect the neck itself and try to gently move the jaw without moving the neck. I know that's hard to do, but you're the first person that's going to see this patient. So just take it with a grain of salt. You can move the jaw without moving the neck, essentially. The jaw can actually be displaced forward and allow the tongue to get out of the way. A lot of times these patients, not gonna lie, they're very difficult to manage, and I applaud each and every one of you guys that sees these injuries out on the field, because by the time they get to me, I know whether they have a neck injury and I know what I can do with it. You guys have to treat it like everyone has a neck injury. So even that head tilt, that jaw thrust, just use both hands and try to keep the neck stabilized if possible. All right, let's go over some non-invasive airways. Okay, so the nasal, I love this one. Your patients are going to be most sensitive to oral airways. If you want them to cough and gag, oral airways are the number one reason they're going to cough, gag, and kind of spit it back up. Nasal airways, they'll have it within their nares and won't even bother. So I love these when I wake up. Of course, if you're worried about head injuries, kind of stay away from these. You don't want to go having CSF leaking out of that thing. Bad. But if you know that you don't have any upper body or any like head injuries themselves, this is a great airway. The way to measure this is take the length of your index finger and your thumb and place it from about the nose to about the edge of the cheek or just under the earlobe. That'll kind of give you an idea of how long you want that nasopharynx or nasopharyngeal airway to be. Here's an example of an oral airway. You can see the difference of where the oral airway is going to sit in the oral pharynx compared to where the actual nasopharynx or nasopharyngeal airway is going to be. You just have a lot more nerves that are more sensitive in the oral airway that are going to cause the patient to cough and gag. So just be aware of that. We're going to go over the most basic oxygen airways and whatnot, or oxygen delivery devices real quick. Blow by, so very good for infants. Sometimes they can struggle for air, but sometimes we can give them too much oxygen. And if they're doing great, here's an example of it. Nasal cannula, they say anywhere from 4 to 6 liters max. To be honest, if you were to put 6 liters of nasal cannula on me, I would rip that thing off in a heartbeat. That thing is dry and it will irritate the hell out of your nares if you don't have proper humidification on them. You'll see those high pressure nasal cannula patients. carrying around their oxygen. It is humidified air, just be aware. So if you have to switch over to yours, just put them on a simple mask if you have to, or a non-rebreather. A lot of your COPD patients are going to wear these at home. Your FiO2 is not as high. Here's your simple face mask. Best go-to at all times for me. You guys know these. I don't need to go over that one. The Venturi mask. So essentially, you can change the amount of oxygen or percentage of oxygen based on how many liters you're delivering a minute. I don't know. Do you guys see any of these in the field at all? Sometimes
we don't use them.
Right. So you see them probably from patients at home. Yeah. I can't. To be honest with you, the only time I've used a Venturi mask is in the endo lab or a pediatric patient. A lot of times I don't see these very often. If you guys do, I can go into depth. Yeah. So it's just basically a delivery system of oxygen to wean the patient off of oxygen, is in short, simple terms. Here's your basic non-rebreather. That reservoir bag will fill as you put a stop finger on it. If you want to blow it up quicker, it'll blow up over time. Patient's not going to really rebreathe too much CO2 if you put them on them, and they're you want the oxygen tank, of course, hooked up first, and then put it on them. But that bag doesn't have to be filled; it'll fill itself within 30 to 60 seconds most times. Anyway, this will kind of give you a little breakdown of your of a deeper in-depth usage of your simple mask, face tints, your Venturi masks, partial rebreathers, non-rebreathers. Basically, it's how much oxygen is being delivered. We breathe 21% at room air, so you can change the percentage based on how the patient is doing. A lot of times, like your COPD patients are going to live in that 92 to 96 area of SpO2. I've seen patients live at 89 to 94%. That's just how they do with how much smoke, how many packs of cigarettes they go through. This was the high flow nasal cannula I was talking about. This is the humidified oxygen through the nasal cannula. Much easier on the nares. Not at risk for a bloody nose here, which is nice. Sleep apnea, COPD patients, pulmonary edema. We don't use them really post-surgical. I use just simple masks when it comes to those. All right, so bag breath. Let's get to the important ones here. If you don't have big enough hands, let me get to it. So here's the thing. So the trick with these is it's more of a feel it out. You can make a C with your thumb and index finger that'll hold the seal over the mask. Your middle finger will go just below the jawline along with your two others. That way you can kind of give a head tilt chin lift as you're going ahead and bagging the patient. If you're not seeing return, that means you either have a seal that's not good, or two, you're not allowing air to escape once you give that breath. So a lot of times you'll notice that you can give a breath, you may see chest rise, but you're not seeing any fog in the mask. Relax your hand after you give that breath. A lot of times that air will escape. Sometimes you can push the jaw too far back to where air does not escape, but it'll go down, which is very odd, but believe me, it happens. If they don't have teeth, sometimes these patients can be very hard to mask because gums just kind of clamp together with how much pressure you put on a bag valve mask. Or their teeth will fall into their mouth and you're having obstruction now. So it's all troubleshooting and getting a good seal and making sure you got good chest rise with them. This is the two-hander. Sometimes with those patients that have bigger necks, bigger cheeks, beards even, you'll have to take both hands and kind of use that and just make sure you got a good seal around, do a good chin lift, give a breath, and then kind of relax your hands, because too much pressure again can push that tongue down and you won't get any fog or CO2 out of it. Inadequate mask size. So if you have too big of a mask for a pediatric patient or too small of a mask for an adult patient, use your oral airways, use your nasal NPAs, nasal pharyngeal airways. That will help you if you're not seeing chest rise. Um, be sure you have enough oxygen flowing through your bag to deliver a true breath. Sometimes if your oxygen tank is out and you're trying to deliver a breath, you may be moving air, just not enough. So you're not seeing enough chest rise. So it's all seeing all different types of sizes, patients, age ranges, everything. So this is just your non-invasive positive pressure ventilation. So patients that you're going to see, we're getting ready to talk about on BiPAP, CPAP. Here's some advantages, disadvantages when it comes to some of these devices that we're getting ready to talk about. You guys can read through those. Let's see here. So your cardiogenic pulmonary edema patients, COPD, asthma, pneumonia patients. Okay, so let's talk about them. So BiPAP, everyone thinks of their like grandpa or someone they know using a BiPAP at night that need, they kind of just like hold their airways open and then kind of remind them to breathe every now and then. Continuous positive pressure. So as you give a breath in, that's positive pressure going in. As they exhale, positive pressure is still being inside the lungs to keep those alveoli open. The difference is that with BiPAP, you give positive pressure in, but that positive pressure now escapes with them as the patient exhales. So there's no continuous. That's what that continuous positive airway pressure is for, simply for expiration or exhalation, I should say, keeping those alveoli. CPAP machines, continuous, so easier to sleep in, less accommodating for breathing cycle. Yeah. Pictures. All right, so here's your BiPAP. Different levels of positive pressure. You can change the amount of pressure being given in a BiPAP. A lot of respiratory therapists that at the hospitals, you go around, ask them questions of how they like to set up their BiPAPs. With me, truly, we always walk around with 5 of PEEP, or positive end expiration pressure. I always start my BiPAPs with at least 5 of PEEP. And then you can work along from there depending on oxygenation, saturation, what their color is, how they're feeling, etc. You don't want these patients air hungry is what I like to call it, but you don't want them over oxygenated, especially if they're severe asthma or COPD patients. As remember, if they live in that 89 to 94 area and you're overdoing them a little bit, we can cause some other issues. All right, complications here. I don't know if anyone's ever worn a BiPAP mask or a CPAP mask. They're very uncomfortable. You can go, like I said, so I start my BiPAPs at 5 of PEEP, just because I'm afraid of barotrauma. Barotrauma is where you get too much positive pressure within the lung itself, and you're causing more damage than anything. If you overstretch those alveoli, they can't properly exchange oxygen, and now we got bigger complications. So air can escape into the esophagus with these. You can cause some abdominal distension. We can cause some air trapping within the abdominal cavity and cause compartment syndrome. Air trapping is what I talked about with the patients that kind of get air hungry or too much oxygen or too much alveoli stretch. Yes, anxiety and agitation. So your older patients that you put these on are not going to like these. Please have some Versed for them or something to calm them down. I've seen them try to rip these things off, and it's not. And they can. 95-year-old ladies have some like Marvel strength, like Hulk strength, and digging their nails in your skin. It's not fun. If anyone hasn't had that happen, just you'll learn one day. Okay, my favorite area of the airway management process, LMAs or supraglottic airways. So let's get through some of these. My favorite one is the iGel. I wish every play. Do you guys have the iGels? Okay, these are the best ones to use. The new ones even, do you guys have the ones with the suction tip on the side? Those are the best. Okay, good to know because Mercy Hospital won't give us these. Literally will trap everything, and if a patient vomits, turn them on their side, keep this thing in, do not ever pull it. If you have an eye-gel in, the eye-gel does a great job of protecting your airway. It says risk for laryngospasm and sore throat. Not necessarily. These eye gels fit softly and gently in the back of the oropharynx and do not cause a lot of any coughing, gagging, anything. Remember, an oral airway, since it's got that hard, rigid tip, lies against the back of the throat. It is more, patients can be more sensitive to an oral airway. I take patients to PACU with LMAs in, and they'll like tongue them out and they'll pull them out themselves. It's wonderful. It's the best thing since sliced bread. Sore throat, I hardly ever see sore throat with eye gels. Okay, the King tube. This one, do you guys use the King tube at all? Okay, this one is kind of, used to? This one kind of was a backup plan to if you couldn't intubate and you tried several times and your airway was kind of getting either, you got behind on either suction or you had too many attempts where the airway was kind of swelling, but you couldn't revert to anything else. This thing was great because that big ball would sit and block the actual esophagus or anything coming up, and then the tip would sit above the vocal cords, and it allowed a second seal to make sure if the patient did vomit and that first big blue blow up, if anything got past it, that second piece would just prevent anything from going down into your airway. So these were kind of that kind of backboard, if you would, if you had a failed intubation. I've only seen these a handful of times in the hospital. So these are the LMAs that we have. Do you guys use these ones at all? Okay. If you ever run across these ones, just remember this rigid tip right here at the very base, or I should say apex of this LMA. That tip can fold backwards as you're inserting it. And if you hook it up to a bag or something and you're not ventilating, just go ahead and stick your finger down there, and sometimes you can push it forward and this thing just kind of folds backwards. You'll have to push it forward and then it'll slide in and catch the airway. Risk of aspiration, you're not going to obstruct your airway. These LMAs are the safest thing you can do if you can't. I mean, the last resort, if I can't intubate a patient, I'm throwing an LMA in. So those are great things to have in your back pocket saying, listen, we've taken 2 looks, the driver's going everywhere, we can't get, a patient to the point to sit still or anything. So, yeah, so. All right, so the double lumen Shileys. This essentially is kind of a better variation than the King tube. Do you guys see these at all? Combi tubes, there you go. Yep. So it's essentially the same thing as the King tube, just I think a better version of it. Don't you guys agree?
This had issues with people not trusting where they were.
Understandably so, because because depending on, I know a lot of, not because we don't have these in the hospital, but a lot of times people were saying that these could go down through the esophagus at times. Like if you didn't properly have it in the right place, blowing up the first tube or the first cuff. But again, it's a backboard. Let's see. So, in my opinion, if you're talking airway management, if you went from intubation to an LMA and you're ventilating, oxygenating, and the patient is safe, stable, and you guys are transporting to the ER, wherever you guys are going, to whatever hospital, leave it in. Do not go backwards in your algorithm to go from a supraglottic airway or an LMA to go try to re-intubate. So that patient's already got some airway swelling, probably got a little bit of bleeding maybe. some mucus, all the above. In my opinion, if you're going to intubate, your first chance is your best chance. Okay, when I was in training, we had a doc say, smooth is fast, fast is steady, steady wins the race. You don't have to go in there and be all flustered. Your first chance is the best chance. Just go in there smooth, kind of identify what you're looking at, and kind of go from there, because your first chance is going to be your best chance. Okay. So you can do bougies. I actually had to use one the other night. Had a patient that I intubated in an emergency C-section. The cuff caught her teeth. Like as I was inserting it in the mouth, I couldn't get the cuff to blow up. I had an air leak. Of course, at this time, okay, I'm through the cords. I'm thinking, all right, let's go ahead and, told the OB, you can cut. I'm in the cord. We're safe to go ahead and proceed with the C-section. Wasn't able to ventilate. I saw it go through the cords with the video scope, and I had an air leak. So I shoved the bougie down, took that ET tube out, and then shoved another ET tube down. So we'll talk about the bougie coming up. Bronchoscopes, do you guys use video scopes or bronchoscopes? You guys have the Cormax, or which ones do you guys have? Glide scope? Okay. Do you guys have the ones with the handle, the Oh, really? Okay, that's kind of cool. I'd like to see that if you guys have one in there. Yeah. Sweet. Yeah. Let's see. Are any of you guys trained to do cracks?
We're doing needle cracks.
Needle cracks?
We're all trained to do the surgical cracks, medical control kind of.
Yeah, it's understandable.
At a point where we need to decide on what we put in a kit, so we have the right equipment always in one place.
If
so
you're gonna,
buy commercial or
right, if I were to say, have you ever been in a situation where you had to crack someone?
Twice. First one I did was a needle. It was a
Okay.
guy who nebulized ketamine that he had stolen.
Oh wow, good for him. Special K.
Well, he was allergic to it.
Huh.
When I went to tube him, I couldn't tell he was having an allergic reaction.
A lot of angioedema, or
his glottis was the size of my thumb.
Oh wow. Okay.
I pulled it out and it was sticking out in front of his teeth.
Oh wow, interesting. The one thing I will say about cracks, I've only been in a situation where I had to possibly do one in the operating room and one in the ER. Make sure you guys aren't in the ambulance running around side to side. You have to have someone like pull over, like tell them to physically pull over. Like,
Second one I did was a surgical.
yeah. Huh?
The second one I did was a surgical.
Yeah.
I used a kit called Pertrate.
Mm-hmm.
It was
In a little separate. Yep. Pull apart, and those are the ones we have. See some pretty gnarly angioedemas. All right, so ET or endotracheal intubations. Why infraglottic airways is up there? My wife is crazy. I don't know if I told you guys this, but I put a whole presentation together, and I have to use hers. So hers is extremely long. So I'm going through this with you guys the first time too. So how do we predict it? Oh, okay. So here's some of your acronyms for how hard something's going to be for a bag mount, or yeah. So your bag, huh? Yeah. So like even your tall people or wide cheek people, no teeth. Like I said, anyone over the age of 55, because they're going to have their airways are a little bit more tighter in the chest wise. It's harder to get some chest rise sometimes with them. Supraglottic airways, a lot of times restricted mouth opening, yes and no. Obesity, that's going to be for everything when it comes to bag valve vask, LMAs, or supraglottic airways and intubations. Distorted airways, if you have some angioedema, stiff lungs, all that. Cervical spine injuries, sometimes those are hard to get around to. All right, let's talk about, so again, I'll roll back to Sadie. You can look at this slide. There's so much going on. So I'm going to tell my wife when I get home, get rid of this slide. Put just acronym Sadie, SADIE. It will cover everything on here. And tell me if I'm wrong. But I mean, you have miscellaneous equipment that covers everything. So I have an answer if you tell me it's not. So anyway, well, I don't even use a tube holder. I use tape. Good tape job. I had an anesthesiologist my first rotation, intubated someone, and I go to, put a clean, good tape job. He goes, give it here. He tapes it all up. He goes, this should take you one piece of tape, two pieces of tape. And he grabs the ET tube and pulls the patient and like lifts the head of it. You have a good tape job. This thing should not move, and it's like yanking on the patient's tube. I'm like, don't do that.
They always mock it.
Yeah.
They always got beer.
Yeah. You guys deal with a lot more of that. Yeah. What kind of tape do you guys use? Do you guys use that orange elastic tape?
No, we use a commercially made Thomas tube holder
Oh, really?
Plastic device.
I'll have to. Well, I'll have to bring you guys some of the orange tape, like just in case you guys ever feel the need. Like this tape, you can throw liquid on it, blood, sputum, patient vomit. This shit sticks. Like it will leave residue. Like I've had beard, like people come out and like I'm doing beard jobs when it comes to taking tape off of people's. Like this stuff works. I'll have to bring some in for you guys. All right, here you go. So first look, anytime you, huh? All right, so we've talked about some things here. So along with obesity or angioedema or large neck, etc., lack of neck flexibility. Sometimes you get those people that have a lot of trapezius muscles or fat around the neck that cannot do any head or neck extension. First thing first, if you can, pre-oxygenate. Like, regardless if you're doing an RSI or rapid sequence induction, anything, like get oxygen somewhere on the patient if you can. It's the best thing that I can tell anyone starting out with any airway. If you can buy yourself an extra 30 to 90 seconds, you're going to set yourself up for success more often than not. So highlight the pre-oxygenation and find a way, whether it's blow by oxygen with a face mask, anything. I mean, just try to get something, or even a nasal cannula. You can intubate someone with them wearing 6 liters of dry oxygen going into their nares. I mean, we pre-oxygenate people with either, we can do our whole bag valve mask, but there's some people that you have to sit there and put some oxygen on them in pre-op and just hook it up to the tank and roll them back to the OR because you know that their residual is not great. So RSI or not RSI. I know a lot of you guys, every time you guys go, you're RSIing someone because you don't know whether the truth is, when their last meal was, what the backstory is. 9 times out of 10, you're not getting the true backstory. So, do you guys teach crack pressure?
Not so much like Celix or burp or anything like that.
Yeah.
A lot of them are taught in their initial exercises too much.
Okay.
I don't.
I'm just curious. I didn't know if you guys still use.
When we do innovations,
Yeah.
for practice stuff, I talk about it.
Okay.
Skills lab.
Yeah. It's still definitely, I mean, even going in, I'll even, if I have someone holding a little cricoid pressure for me, I'll take their hand and I'm able to use the burp method, backwards, upwards, rightward pressure to help visualize the chords or pull that airway into view. Because a lot of times, like I haven't said it, but the airway itself will sit just to the left of the so the esophagus and the trachea are lined up like side by side, but the trachea is more to the left, and you can kind of pull that into view a little bit. So it's a good way to kind of facilitate where your airway is. So your basic sedation, I'm not in charge of going over drugs. Do you guys have phenylephrine like syringes at all? Okay, so you guys kind of have to protect yourself with etomidate then.
Well, we mentioned it earlier. We have a couple of different recipes for RSI.
Okay.
Ketamine and rock, etomidate.
Just be sure you use enough ketamine so the patient's not tasting colors. I had a patient wake up a couple months ago and he says, I didn't like that taste and colors thing. And I'm like, okay, I'll give you more next time, or just not give you ketamine at all. Paralysis. So your succinylcholine is going to be your depolarizing, huh?
You can take all 6 of those, and there's different ways of approaching it.
Oh yeah, 1,000%. My favorite is cardioprotective is fentanyl. I'll use fentanyl, phenylephrine, low propofol, and so fentanyl and lidocaine to me block the sympathetic response to a DL. You don't get that elevated heart rate, blood pressure, unless you need it. Like unless you got old granny that weighs 80 pounds soaking wet, that you're like, okay, your pressure's already 95 over nothing. Like, maybe we need a sternal rub along with a nice little DL. So just be sure you have a little something on board for the trip as you're bringing them in. That's all I'm gonna have to say about this. You guys can go over drugs. I will do a pharmacology lecture whenever you guys want me to. So here's kind of your sniffing position on your right, kind of getting all 3 of your axes aligned, your oropharynx, nasopharynx, and larynx. All the one to the right is kind of a sitting intubation. How often do you guys do this quite a bit at all, or are you guys more or less laying down? Okay. Do you guys do like crisscross applesauce where the patient's head is kind of in your lap, or do you guys do? I know a lot of times when I was practicing school, I would have to physically lay down because I'm so tall that I would kind of get down almost in a combat-like position, laying down. So if you have to sit your patient up, do it. Like you can always use a step ladder if need be. So.
And in my trauma class, driver.
Yes, good call.
Any passenger.
Yeah, for sure. Okay, so I'm sure you guys have debates on whether you're a Miller or a Mac fan. I'm a Miller fan through and through. If you use a Mac blade, I'll make fun of you and call you a potato digger. So.
I can use either.
I can intubate a rock with a Miller blade, No, but on a serious note, use the blade that whatever you're comfortable with is my thing. What I will tell you, if you have an easy airway or have a patient with no teeth, pull out the Miller blade. Get comfortable being uncomfortable in situations that you have help, have an extra set of hands. Know your equipment. Know every piece of your equipment. No matter how comfortable you are with a Mac blade, it works every time. The one time that you're going to need it, it's not going to be in your bag. Someone forgot to restock it. Someone did this. Someone did that. Miller blade's all you got. Just get comfortable using everything in your arsenal. That's all I'm going to say about different blade types. These, yeah. So is it similar to this? Okay, perfect. Yeah. So we started getting those at the hospital too, which is nice. I haven't used one yet. Try not to. So we have the glide scopes. You guys have the glide scope handles, which is nice. Are they reusable or are they disposable? Okay, disposable. A lot of times these will, all the time these will mirror your Mac blades that you'll see. Don't open one. I don't want to waste one. I'll take a peek at it here in a bit. Blind nasotracheal intubation. Okay, so this slide, I'm going to go ahead and kick rocks. I'm going to tell you to kick rocks if you ever tell me that you came in and had to nasotracheal intubate someone, because yes, you can do it. Yes, this is very complicated. You will need hemostats to even try to get this, because you'll need to, one, soften the tube. What?
I might be a
Have you,
blade user.
oh, that's fine.
Done that 8 or 9
Have
times.
you really?
Yeah. 8 or 9 times successfully.
I had to RSI someone nasotracheal from ENT, and you know what? It's the last time I will ever do it, because it was not an emergency surgery. This thing, okay, so when you went in, did you have to soften the tube?
Yeah, a little bit.
And probably use a smaller tube. Did you use do you use oral rays or nasal rays? Because there's different types of tubes, or do you use a regular ET tube? Okay, so a lot of times our dental surgeons will like to use oral ray or nasal ray tubes. So with the regular ET tubes, you just have to kind of pick your battles with how tall the patient is. Sometimes if you get a very tall patient, And sometimes if the nares aren't big enough and you can't get an 8/0 tube in there, you risk bleeding. You risk a lot of complications.
Smaller probably.
Yes, size smaller. The problem is the tube gets shorter. So you can do this probably. Biggest thing is, can you get it through the cords and can you inflate the cuff? Once you get it pretty much in through the nair, the right nair is always going to be larger. You want to see, if you can, open the patient's mouth and see the tip of the tube coming down into the oral pharynx. Then go ahead and stick your blade in, and then you can advance and try to turn and twist. Biggest thing is trying to, once it makes that turn in the oral pharynx, it's very hard. As long as your trachea is anterior, might be easy, it might slip in very nicely. Sometimes it will catch the vallecula and it will go to the backside into the esophagus. So that's times we do Kelly clamps, or we'll do McGill's, and we'll have to grab, and you'll have to MacGyver it into the airway. So
Every time I was successful, that made it the most simple without any tool like the band device or any other kind of thing. It was just a tube and me.
Yeah, and sometimes you can maneuver the neck to where it is.
Once I got it passed, I knew it was in the back of the oral pharynx, and just inflate the cuff.
Really, that's insane.
More than 10.
More than 10?
To get that cuff big and fat.
Yeah.
And if it advanced and it stopped, I was probably at the trachea.
Interesting.
If it went on past and went like all the way up to their nose,
right,
I knew that I was probably in the soft esophagus.
Interesting. Okay.
So if I got to the trachea,
what was the? You mind if me asking? What was the patient's?
They're all complicated.
Well, presenting with, like, were there like
Yeah.
oral, just jaw just broken, not able to move jaw or anything?
It was clenched.
Yeah.
Jaw, stuff like that. All those
That's
things.
understandable.
Some patients, this was admittedly over 25 years ago.
Gotcha. Well, okay, then I take back that. I take back the go kick rock.
So
Really?
as soon as that cuff inflated, it hit the trachea. I'd deflate the cuff, advance, reinflate, and be it every time.
Interesting. So I take back my slogan of kick rocks with this. If you have a patient that you can do it or need to do it, please do.
Right.
There you go. See, I'm trying to work on my jokes. I shouldn't have said kick rocks. I apologize. But it's like, that's something I've never done, and that's soften. Yep, it kind of curls it. That's I usually stick mine in warm water, but I've got the time. Unlike you guys don't know what you're walking into. You stick it in warm water, you can nice and soften it up, and you can maneuver it however you need to. So yeah. And sometimes it'll fall in. That's a good idea. That now with any nasotracheal intubation, I will always use a mech blade. I will always revert back to a mech blade, because Miller blade will actually, if you get too deep, that the tip of the blade going past the epiglottis or the vallecula to lift the epiglottis can catch the tube, and then we'll let the tube go through. So I definitely am a Mac blade user when it comes to nasotracheal intubations. So, all right, so complications here. We can read through all of these. ET tube misplacement, dislodgement, main stem. So go back to the depiction of the lungs. You'll see that the right main stem comes off at a less angle than the left main stem, so you're more apt to be in the right. So just be sure you're listening for sounds. Be sure you're noting exactly where the ET tube is, because a lot of times when you guys move patients over, the tube does come, in or out a little bit. Just make a mental note of what it's at. If you had good bilateral chest sounds when you take them in, just remember you're our eyes and ears when it comes to all of these factors. Sometimes they can vagal down. Hypertension. Never seen cardiac arrest during my intubation. I've seen it a minute or two after. I couldn't tell you if it's from the actual intubation itself or it's from the drugs. Most likely it's the drugs, but I have seen it. You can injure the oral pharynx or the cords. Gastric perforation, ET2 cuff leak. Sometimes your cuff, do you guys test cuff pressures? Or just kind of blow them? Yeah, so just blow them up. Sometimes you will have if you have a cuff leak, you can put some more air in it, feel it deflate. Sometimes that that cuff will catch on a patient's teeth, or it just does have a leak and you got to interchange it. If you got some clots going in there, if the patient's like bleeding into the lung and cough, you can have some ET tube obstruction when it comes to some blood in the tube, or you can, if the patient's clenched down or biting on the tube, you can have some obstruction, hyperventilation, failed attempts, managing intubation. Here's your long list of everything that could be a factor when it comes to intubating someone. Huh? me and you both. The only thing I don't have is the beard yet. But I tell you what, wearing a mask with a long beard is not fun, so I cut mine. I'll let you guys read through all of these. This is what I was saying with managing intubation. Your first chance is always going to be your best chance. Slow is smooth, smooth is steady, steady is fast. So just go in, identify your structures. You don't have to go fast with it. You could, I'm sure you guys have the pulse oximeters that are beeping at the times. Even if you hear it kind of trembling down, take a breath. You're okay. Continue, and just be calm with it. The calmer you are, the more steady your hands are going to be. The more happy you're going to be successful. And let someone know. Like, I know you guys do it. You guys are in teams, right? At all times, mostly. You guys are a group of two. So, if you have something, forgot the words of it, but doing something over and over and getting the same result is insanity. I thought it was insanity or something, but anyway, change something, like whether the patient has to be changed position, or do you need a more shoulder roll? Do you need a little bit more head tilt? Do you need that backwards, upwards, rightward pressure? Do you communicate with each other and just be, don't go in there and say, oh, I can't see anything. Like, what can be changed? Like, throw some ideas, and if you have to swap places, do it. Like, it's okay. Everybody misses an innovation. There's some days you can't hit the broadside of a barn, and then there's days that you can close your eyes and throw a dart and it hits the middle every time. So it's nothing to be worried about. You guys are all working for the same goal of the patient. Okay. Let's see here. Here you go, SpongeBob. Yep. Don't panic. Biggest factor I can say is if you can't intubate the first time, go back to your bag valve mask. Make sure you're moving good air. Make sure you're seeing good fog, chest rise, all the above, and make your changes. Like brainstorm, as long as your patient's sat and good, throw an LMA in there and go from there if you need to. If you've done multiple times, use your oral airways, use your nasal airways. All of those are there for your advantage. It's like doing a layup. Do you want to finger roll it, or do you want to properly put it off the backboard and do the basic stuff to have the ball go in the hole, 98% of the time. You don't have to be cute with it. Doesn't have to look good as long as it works. Okay. Yeah, exactly. So this is, like I said, this is something I've never done. I hope I never have to, but there's a couple different ways that you guys can do it, and feel free to chime in since I know that you've had these situations. Not many, but if you've seen one, you've seen more than most people. Let's put it that way. I know some anesthesiologists that I work with that are trained in them. Thank God they've never seen them, is what they say. So a lot of times this is going to come from, book answer is going to tell you these patients are coming in with severe angioedema, whether it be an ACE inhibitor allergy or some sort of allergy, bee sting, something where it's causing their airway to just collapse. More soft tissue, less distinct airway structures, all that. So.
Instead of transcript of jet, it's going to work once. Then give them one puff of air.
Oh yeah, it's
all you're going to get.
Yeah.
You got to get it out.
Yep. So here's your surgical. Yeah. Here's your the most controlled of controlled situations you can get of being in an operating room and having a surgical crike where we do our trachs and everything. I can go back to the oral, but this kind of is a depiction on exactly how So you want to, it's in between that cricoid membrane, um, in between the cricoid ring and cricothyroid membrane. God, it's just, I hope no one has to see this. If you do, it's just a situation that you definitely don't want to be in. I've never even seen the Selleck maneuver with these. Is that the needle aspiration that you're talking about? And then would you go in through and use that as a the guide wire and slide the tube over the guide wire?
Have that.
They do?
So, once you make your incision, you either go in with the needle or you don't want it.
So I was always
Right.
So I was always taught that once you do your vertical incision and you can get through, once you needle it and aspirate that you're in the proper space, you can take your finger and go ahead and use your finger to make a bigger hole. And then you can go in there with a smaller tube, of course, and put your ET tube in there if need be, or if you have the transtracheal jet tube that you want, or
the way ours went in was, yeah, the tube had a little wire on it, and you go in through the needle, the needle would split apart. And
No.
pull the needle out.
A lot of times, I know that they're trying to come up with a smaller bougie that they can go in through there, and then you can slide your ET tube with the bougie. Yeah, I know that they've been playing with those ideas. They just haven't really. I mean, even so, you can take your own bougie. You can cut your bougie and use the back end of the bougie, the end that looks like a little hook. You can use that once you feel with your finger. You can use your bougie, stick it in there, and then you can slide your ET tube over the top of that. Problem is you have to make sure it's long enough that the ET tube covers it. So that's why they're trying to make the bougie and an ET tube that's short enough for the bougie to come all the way out. That way, once you advance, you take that bougie out. So I know they've been playing with that. Post intervention, make note if they're a difficult airway for you guys. When you bring them in, it's a huge help for us. We'll even document it, note it for anything. Note how many times it took, what you were seeing in the airway. Do you see, any polyps? I've gone down in there. I can't tell you how many patients I've seen over the last 24 months. I'll go in and intubate them, and they've got polyps on their arytenoids or a polyp on their vocal cords, and you're like, oh, it's something that I wish I could take a picture of, but you just got to pass it on because that's something that airway wise, that's always what we like to know. And for you guys too, like hey, like something's not going, or if they have a goiter, or like all of these things, if they've got increased thyroid membrane size, or you guys see it all. So, and then anything that you would, working back over, think about it like, okay, what could I have done differently to make it smoother? What could I have done? Did a patient need an oral airway? Did they need a nasal airway? Here's your transition to care. We talked about all this. Sorry, I know it's running up on 4 o'clock and you guys are ready to get out of here. Confirm your placements with your end-tidal CO2. Let's see what else here. This is kind of your airway management kind of guide of how they would do it step by step, of like, okay, your algorithm, I should say, or what you could do for each. So I'll let you guys read that. Same thing here. I won't let you guys don't need to do the case studies. I told you I'd make this less. Is there any questions? Let's go over any. This is what I wanted to get to. Anyone have any questions, whether in here or? I'm really sorry about my new PowerPoint that didn't come over. I'll send it if you write down your email. I'll send it over. It's got more kind of basic stuff.
What led to the TPI was originally tube the guy
Mm-hmm.
because he was on the floor they were doing CPR when he got there, and his nebulizer was sitting over here, so everybody just thought, well, they went to whatever.
Oh.
So, she was a, total, I saw the court.
It is.
No, I did. And I went to bag him, and it was like a lot.
Well, he works for
I
Mercy.
was like, okay, well, now I gotta pull it out. And when I pulled the tube out, I pulled it up a lot of out of it. Sticking up about it.
That's crazy.
And then they got a little ketamine bottle that stolen from the vet.
A vet. Oh my
So he was
god.
nebulizing it, that's what the reaction to it.
I take, does that sound familiar?
Let me look here.
HY. Yeah. One of our Mercy employees up north.
Yeah, but it's the thin. Yeah. It will stick to everything.
That's what he said. Said it was stupid expensive.
I mean it.
Shoelace ties.
Yeah, wrap them around the. Yeah, you wrap it all the way around, then you can tie it. Yep.
And when we had a chance.
Mm-hmm. That's another good idea. Yep.
So what I like now is our two tamers are hard plastic. So
Mhm.
you can use them for ET2s and the eye gels to secure them both.
Do they sit in between the teeth too? Does it have like a bite block in it? That's nice. That's very nice.
The strap's fairly wide. We have to teach them to make sure to get that up around the back, like of the bone, and not pull it real stinking tight on the soft tissue of the
Yeah.
neck. It'll put pressure on the carotid.
I don't see any questions.
Okay.
Oh, thank you.
Well, sorry we kind of flew through that, but I figured you guys would want to get out of here on time. So,
Appreciate you coming.
of course.
Yeah, no, it's all good. All right. Well, like the blurb said there on the bottom of the screen, we're signing off for today. We'll see you in the morning.